afternoon, everybody. I'm Christy Koenig, the EMS Medical Director for the County of San Diego. Thank you so much for joining us for the next lecture in our series of evidence-based medicine presentations. Today's topic is pre-hospital treatment of sepsis, and our presenter is Dr. Claire Gahm. We are delighted to welcome Dr. Gahm, our UC San Diego EMS Fellow, to deliver today's EBM talk. Prior to joining us in San Diego, Dr. Gahm completed both a pediatric residency and a combined pediatric emergency medicine global health fellowship, during which time she also completed her MPH degree and served as an EMSC fellow focusing on pediatric disaster preparedness. We've asked Dr. Gahm to review the current literature on pre-hospital treatment of sepsis, along with evidence of specific emerging data. For example, the utility of pre-hospital point-of-care lactate level measurement, and to recommend any science-informed changes we may want to consider for our County of San Diego sepsis-related protocols. Those of you who have had the pleasure of participating in Dr. Gahm's educational sessions over the past few months know what a knowledgeable and engaging speaker she is. We are certainly in for a treat today and look forward to learning the most up-to-date evidence behind pre-hospital sepsis treatment. Over to you, Dr. Gahm.
Perfect. Thank you so much, Dr. Koenig. Yeah, and thank you all for joining us on this rainy Tuesday. My goal for my lectures is always to make them open forums for discussion, so please feel free to interrupt me. And certainly if someone, Christy, if you're moderating and see any questions or comments in the chat, be sure to raise those to me. All right, so our goals today, like we mentioned, really is just a brief overview, again, of sepsis, why we care about sepsis in our pre-hospital setting, reviewing the barriers to sepsis care, discussing current evidence-based treatments of septic shock and this concept of the pre-hospital golden hour, which has been adapted from our in-hospital and ER-based trauma and sepsis golden hours, and then to outline our current protocols. So why do we care at all? It's because sepsis impacts our population tremendously each year. This is just statistics from the CDC for adults, not pediatric patients. But specifically, 250,000 adults will die from sepsis every year. And why we care, especially in the pre-hospital setting, is because 87% of those cases will originate outside of the hospital. So we truly are the ones responding and have the opportunity to make an impact. As a reminder, in general, sepsis can be from a bacterial infection, as you see on this slide, but can also be from a viral infection like COVID and influenza and rhinovirus, notoriously can cause sepsis. You either have viremia or bacteremia leading to this cascade of inflammation that ultimately leads to leaky vessels and end organ damage. This is just another diagram depicting that. Ultimately, you have a buildup of acidosis in the system. We all probably remember from our elementary school days learning about anaerobic versus aerobic metabolism. So when you have a deprivation of oxygen, as you do with this lactic acid buildup, you end up in anaerobic metabolism, which then downstream leads to this idea of destruction and cell death, which is where we start to see in our severe sepsis and our septic shock, a lot of those clinical indicators that we think of with regards to sepsis. Since we'll be talking about lactate a little bit more later, don't need you to learn anything on this slide other than the fact that you get an increase in lactate as you have hypoperfusion and tissue hypoxia. So again, the downregulation of that inflammatory cascade is going to be hypoperfusion of critical organs, heart, kidneys, brain, and the side effects, or not side effects, the clinical indicators that you start to see because of that, and that buildup of lactate. The only thing to note on this slide really is the idea that sepsis is a distributive shock. So again, reinforcing the idea of vasodilation. Sometimes people will think of it as warm shock initially before you progress to those end organ effects, where you start to see more of the heart failing. And so you can see flash capillary refill. The patients will feel warm and hot. We think of inflammation, we think of red. So thinking of sepsis as that red will give you an idea of the distributive shock. One of the things that we'll talk about a little bit more later is this idea of early warning scores systems. SIRS was the original early warning score developed, and it really was just an indicator, not necessarily of sepsis, but of a general inflammation in the body. And so SIRS being signs of systemic inflammation, needing at least one, if not more, of the following. So temperature either elevated or hypothermic low, tachycardia, tachypnea, elevated capillary refill indicating poor perfusion. And then later on, they added that end-tidal CO2 measurement as part of this. But really, that's related to the ensuing tachypnea that you often see, therefore breathing off the CO2 and seeing a decrease in that end-tidal measurement. The 2017 statement from ASAP endorsing Surviving Sepsis campaign, again, just tried to break down the definition. The only thing I really need you all to recognize from each of these definitions is that there is a continuum. You have the early indication of inflammation, progressing to sepsis, progressing to severe sepsis, and eventually to septic shock. And the reason we care is because we meet our patients at some point in this continuum, and we're not sure necessarily what has gone on prior, how long they have been sick, but understanding and being able to identify very quickly how sick the patient is will allow us to provide the most optimal care, as well as encourage our communication with the destination that we're bringing our patient to, and give them an alert as to what's going on. The prognosis based on severity, so again, in that continuum of sepsis, getting up to septic shock, pretty high mortality rate when you do end up at that septic shock point, 46% of patients. These are very old statistics. I was trying to find a nice summary of the newer statistics, and I think that first CDC slide captures it the best. But again, we're trying to prevent our patients from reaching that point of septic shock or treat them as aggressively and as rapidly as possible when they are there. And ultimately, the treatment priorities, as with any illness, any sick patient that we identify, our ABCs are critical, right? So that's really all our sepsis protocol deals with is our ABCs. It's just in a fine-tuned manner. So you have your ABCs. From a hospital standpoint, they're finding and controlling the source. From our standpoint, we're working on evaluating and maintaining tissue perfusion. Some of the barriers to sepsis care in our pre-hospital settings, none of this will be a surprise. Probably you have a few other points that you could add to this slide. But ultimately, it comes down to all of our barriers, right? We have limited tools that we are able to use, limited resources, in some cases, either prolonged transport time or limited transport time to actually intervene for patients. And then a recent study had shown that only about 61% of EMS clinicians in the urban system that they were serving were aware of all sepsis indicators. So there's always education gaps. And a lot of that comes with the fact that sepsis is a hot target to study, and it's constantly being updated. That's why we're talking about it today. So how do we continue that CE effort to maintain our education for all of our providers on our current sepsis indicators? Briefly, I just want to highlight what our San Diego protocols state as of now for our sepsis in both adult and pediatric patients. So here we see for our adult patients a list of the vital signs for suspected sepsis. And we'll delve into those a little bit more later, but ultimately need to have any history suggestive of infection. So not necessarily fever, potentially, cough, URI symptoms, vomiting, diarrhea, and then 2 or more of the following. So fever over 100.4 or under 96.8. Really important to highlight both high and low temperatures in this case. And specifically our elderly population over 65 is going to be more prone to those lower temperatures. Heart rate over 90, respiratory rate over 20. And then within this, we capture that end-tidal CO2 of under 25, That is, again, very much intertwined with that respiratory rate. So if you see one, you'll probably see the other. And then leading into our initial bolus, here I just want to highlight that this says regardless of lung sounds for the bolus. And then again, repeating it regardless of lung sounds. The reason I say that is that when we get into our pediatric sepsis protocol, they do make sure that you are listening to those lung sounds and making sure there's no rales. Moving into our pediatric protocol, again, 2 or more of the following. Here we start to use more of our end organ clinical indicators. So for instance, our altered mental status with the brain involvement. And then hypotension is actually taken into account in our 2 or more. And over here, you can see our indicators for hypotension in pediatric patients. And then ultimately after fluids, if the patient remains hypotensive, allowing with a base hospital order to give a push dose epi. And it's the same for our adult patients. It's a base hospital order. So that leads us into this concept of the golden hour. You'll have to forgive me my voice. So this initially, again, was developed actually for trauma systems, but has been adapted to any kind of sick alert patients. And I think really plays into this idea of arrival on scene, very early immediate recognition and identification of sepsis, as well as the severity spectrum. Because ultimately what that's going to do is prompt you to rapidly begin that initial resuscitation with your ABCs and your fluids. And you can see here, again, it's listed for the emergency department, but they actually include in the first 15 minutes the administration of both fluids and antibiotics. But ultimately by the 60-minute mark, having administered fluid resuscitation, antibiotics, and being at the point that you're deciding about pressor support if you have not reversed the shock state. So the golden hour really written more for shock, but I think can be adapted and applied to the idea of general sepsis management, really encouraging our early identification. And then ultimately, as we start talking about an alert system, potentially playing into that alert system. So we're going to kind of break down again this idea of the golden hour as we go through the rest of the talk. Please feel free to interrupt with questions or comments. So our first concept is this identification. So this is where our early warning scores, our vital signs, and our alerts come into play. The first thing I did want to just point out, our vital signs in general in our current San Diego protocols are up to date according to the literature in terms of the catchment of those patients that would trigger sepsis alerts. And so it's that tachycardia and tachypnea, temperature changes. The one thing ours does not include for adults is more of that idea of altered mental status, and it does not include blood pressure changes. I think ultimately, yeah.
Since you invited interruptions.
Please, yes.
Comments on alterations in geriatric patients. We're talking about pediatric patients, but geriatric patients who, for example, may not be able to mount a fever or may be more likely to be on beta blockers, thereby keeping them from their heart rates going above 90, that type of thing.
Yes, I think that's a really important point to highlight. And I think that that is why potentially incorporating mental status and blood pressure changes into our adult sepsis vital signs may be helpful, specifically for those older populations. But I do think that having a low threshold for suspecting sepsis in our elderly patients is important because they are one of our high-risk populations. And then I think bringing up the beta blockers is a really important point, considering so many of our patients will be on beta blockers. Was there any other question or comment about that specifically?
No, and I've been monitoring the chat and nothing there so far, so please continue.
Okay, awesome, thank you. And it actually plays right into this slide. So that was really what I was going to bring up, is potentially incorporating blood pressure and mental status into our adult suggested sepsis finds, or with a caveat and highlighting our elderly patients being cognizant of that and not necessarily ruling it out if the heart rate isn't elevated, for instance. Tactile temperatures is something that we often ask whether we can trust, whether we can use. you don't have an accurate core temperature potentially, or your initial assessment, you notice the patient is hot, how predictive or precise can that be for our patient population? And quite a few studies have actually delved into this in the pre-hospital setting specifically, and actually said that that hot or not idea, so not necessarily saying hot, not, or cold, but hot or not can be pretty telling of temperature changes for patients. More often, it's temperatures that are over that 38.5 to 39 that people are being able to tell based on tactile temperatures that they are hot, but can be useful in a determination of patient's temperature. And so just being aware of that, really the only thing that can be missed is this idea of cold, especially for our elderly patients who may have poor peripheral perfusion to begin with. You feel the hand, feel cold all the time. That can be difficult to discern. Altered mental status is another important indicator, but I really do want to highlight the fact that this is more of the end organ process. So here you're talking more about severe sepsis to septic shock with altered mental status. It can be difficult in our elderly patients as well as our very young patients to determine mental status changes in general. When you come into play with dementia, babies who are crying or sleepy, parents will bring up the word lethargy frequently, and it can be hard to decide where they are in that spectrum and that continuity of mental status changes, but really still important to take note of because of the fact that it is such an important indicator of your sepsis continuum, your severe sepsis and your septic shock. It actually has in the neurologic world a specific name called sepsis-associated encephalopathy. Again, that's just the idea, like acute kidney injury, of the brain being involved in that acid buildup in the end organ dysfunction that we're seeing. And notably is not meningitis. It is not an infection in the CNS space. It is a byproduct of that acid buildup of that end organ dysfunction. But being very aware of altered mental status in general. And then lactate, like we mentioned, we really want to talk about lactate. Just a quick summary in general from what I read and looked into in, I think, almost 50 studies. Lactate cannot be used diagnostically in the pre-hospital setting to say, yes, you have sepsis, but really all the literature has moved towards supporting a prognostic use of lactate to say, here's the severity, here's the resuscitation based on the severity that we're expecting and that we need to communicate to our destination. And so a number of systems have actually started to adopt its use more as a prognostic factor than anything else. And that's really all that this slide says. Obviously, everyone's always trying to decide what threshold, what number do you say yes or no, you're more at risk, you're not at risk. 4 has become sort of this magic number that everyone has started to use. So greater than 4 being more prognostic of a severe sepsis, septic shock, under 4 being maybe less suspicious, but that number is always changing. You're always obviously missing patients that could be severe sepsis with a lactate of 1. So it's never supposed to replace all of your other clinical indicators, but it can be used more as a prognostic adjunct. So I think it is an interesting idea to bring into play in the pre-hospital setting, but also has its own barriers to rolling out. On this slide, you can see, again, it's that purchase of point of care equipment, putting that on your ambulances, providing the education on how to use it, obviously maintaining the equipment over time, providing the continuing education. So a lot of systems have opted not to use it because of this idea of cost and the fact that it's not necessarily diagnostic, but is more prognostic. That being said, I think when you get into this idea of sepsis alert systems, it can be a useful tool. So the jury is still out as to yay or nay, included or not, but we have moved even in a few short years, 2016 to 2019 here on this slide, but really to 2024 now, to saying it is being adopted more frequently in pre-hospital settings, a lot of times with hospital-based EMS systems. to communicate with facilities that you have a sick patient incoming, and here's what needs to be ready when that patient arrives. So I would be curious just to pause really quickly here and ask if anyone has any experience with using lactate POC and other systems you've potentially worked in, or just in your own experience in our pre-hospital setting.
I can tell you we looked into it for our departments, and it would require a significant amount of oversight, because you would have to now make you a laboratory, which means every fire department would have to be a laboratory. It was not an easy hill I was ready to climb, so I stopped investigating it.
Yeah, and that's very much in line with what I was hearing and reading about. So that makes sense. Thank you for sharing that.
Yeah, and stuff like the iStat can be finicky. I've used that before as part of our DMAT deployments, and it's finicky, and they got to be stored in a cool environment, and they really susceptible to bubbles, and that can be a challenge if you're moving.
Yes.
There's a comment in the chat about that says CLIA and CLR nightmare. And then Dr. Vitolani, do you want to go ahead?
Yeah, at my old agency, we set up a moderate complexity lab so that we could continue to use our iStats for our mobile integrated healthcare team. It's difficult. There's a lot that goes into it. It's possible, especially if you have active physician involvement, because a physician who takes a course can serve in sort of multiple functions that are required. But it's definitely requires a lot of upkeep.
Yeah, absolutely. I have worked with iStats in the global health setting, and I think that it was broken more days than it worked. And so again, it can be a bit of a headache to maintain and use, but certainly if you're able to navigate that, could be useful. But yeah, thank you so much for everyone's feedback. I think that's very telling of the current consensus that's out there. So moving from our discussion about lactate and this idea of early alert system into what does a pre-hospital sepsis score look like? What are the current tools that are out there? Which is the best one? There are so many acronyms in general, it's hard to keep track. So I'm going to go through and highlight 3 of the ones that seem to be potentially the most predictive and the most useful. And then ultimately, hopefully arrive at a conclusion for the one that is currently the most adopted and potentially that the studies support as the most useful in pre-hospital systems. These in general rely very heavily on our vital signs. We don't have a lot of other information. We're not using laboratory results. We're really looking at vital signs. And then the ones that include mental status, or GCS sometimes is how they'll classify mental status, usually are the ones that have the best predictive values. So not just the vital signs, but that end organ involvement as a way to say, this is a severe sepsis case, let's get moving. Again, these were originally created for the inpatient setting, like so much of our work in these scores are, but then applied to pre-hospital settings to identify our critically ill patients and predict patient outcomes potentially. And so that's where we're going to move into our first score, which is called the PRESS, or Pre-Hospital Severe Sepsis Score. The study that looked at this evaluated over 60,000 EMS encounters, but ultimately found that 555 of those met criteria for analysis. Of those 555, 75 patients had severe sepsis, and only 14 of those were identified by EMS clinical judgment. So the start of the study just saying, this is why we would like to have a scoring system. This is why we use scoring systems for STEMIs, for strokes. It's to take off this subjective clinical judgment and say, who are the at-risk patients? What are we looking at? 6 EMS characteristics were found to be predictors of severe sepsis. You can see those off to the right. So they thought elderly patients specifically, long-term care facility, nursing home transports, call going out that it was a sick person, already priming and prompting the crew that arrives that this person is sick. The age, as you can see, kind of indicator there, temperature, blood pressure, and oxygen saturation. At a predefined threshold of 2 or more points, the pre-hospital severe sepsis score sensitivity was pretty high at 86%. So it felt like it did very well for their population. And again, this was a study that was conducted in Atlanta. The vital signs, as you saw in the previous slide, that they highlighted were heart rate over 90, respiratory rate over 20, and pretty generous here, our blood pressure under 110. Definitely would capture quite a few patients with that blood pressure measurement threshold. The other thing that I just want to point out again, this also reinforces the use of tactile temperatures in our initial evaluation models. They weren't measuring temperature numerically, they were measuring it with a tactile, hot, normal, cool, or cold. And you can see the statistically significant values are those same values that I already mentioned as the indicators that they ended up creating the scoring system around. Here you also see that they incorporate GCS. So 15 patients without severe sepsis, 14 and under, so any kind of alteration in their mental status, more predictive of severe sepsis. So that is the PRESS score. Again, they felt that it did well. You have that 86% score sensitivity, but you do have quite a few patients that you're going to capture who potentially are not severe sepsis when you have blood pressure thresholds at 110. What's interesting is then we go into this critical illness predictive tool that was developed. You can already see how different these parameters are in terms of the vital signs. These patients, I would expect in all cases to have severe illness of any kind, right? Your adult has a respiratory rate over 36, blood pressure, here they're saying if it's over 90, they don't get a point, so they're okay, which means that any patient with a blood pressure under 90 is sick and gets a point. I would expect an adult with a systolic blood pressure of 70 to 80 to be sick. Pulse over 120, not taking into account, again, patients on beta blockers, potentially who would not show the same signs of tachycardia. Your pulse ox is under 87%. Goodness, your GCS under 8. So what's interesting about this tool is, of course, it's going to find all of those severe patients because the vital sign thresholds are so extreme. So it has a good positive predictive value, but it excludes quite a few people who potentially could still be severe sepsis or sepsis, and you're not capturing that population. And then the QSOFA, that's probably the one that we hear thrown around the most in our pre-hospital work. It's nice. It has an mdcalc.org or .com little plugin tool. You can just type in the values on your phone and pulls up the score immediately and tells you how to interpret it. So this is around and from a tech standpoint used frequently. Here you have it introduced again in 2016 by the Sepsis 3 Task Force. Their goal was to replace SIRS criteria, just to kind of augment that and then say, how can we be better at predicting our patients who are further down the line with our severe sepsis scores? So again, it includes altered mental status, which is any GCS under 15, elevated respiratory rate, and systolic blood pressure under 100. It does not take into account heart rate. I think specifically when I was reading, because of the fact that there can be such variability with our adult population and our elderly population. So it really highlights more of that mental status change with blood pressure and respiratory rate change. And then ultimately, very simple, 0 to 1, not high risk, 2 to 3, high risk. The goal here is to say who's at high risk for deterioration, who do we need to be aggressive in resuscitating. The study from 2020 tried to essentially look at all of these prediction tools. So I think there were 21 different scoring tools and say what is going to be not only the best predictor, but also the most usable in our pre-hospital setting. Because it does take a lot to introduce a scoring system, and usability is just as critical. Teachability, the communication between pre-hospital to hospital, all of that needs to be taken into account. And they really felt that based on this study, QSOFA was the best score from a usability and a prediction standpoint. So simple to calculate, You already have a tool online that you can use. So there's no thought involved. You just input a value. You can see the others that I highlighted. Not surprisingly, the y-axis here is probability of sepsis diagnosis. That critical illness prediction score was almost 100% predictability. SIRS all the way down here, right around 35 to 40%. And then you kind of have QSOFA and PRESS in between, but QSOFA doing pretty well here, around 85%. And then most recently, just this past November 2023, there was another systematic review that came out supporting essentially the same review that I just highlighted, which is that there are quite a few screening tools, quite a few scoring tools. Of all of the studies they evaluated, only one was actually conducted in the pre-hospital setting. All the others were in-hospital or ED-based. And ultimately, after reviewing all these different early warning system models, they felt that QSOFA demonstrated the highest specificity in differentiating between sepsis and conventional infections, and most successfully predicted mortality. So their proposal based on this evaluation was actually that a combination of QSOFA and SIRS may be useful to avoid practice paralysis as they continue to evaluate other potential scoring systems, but that the two together could be useful in the pre-hospital setting to be an alert system. So another pause quickly, just to mention all of those early warning scoring tools and to ask this question, whether our next move in San Diego County should be working on a new alert system for sepsis. And I know we already do this fairly organically, but we don't have an official alert system. I'd just be curious about the discussion.
Question or comment from Todd, go ahead.
Yeah, thank you for the presentation. I think as far as the pre-hospital setting, it would be real beneficial to maybe add some of the pediatric criteria, or at least address things like, age or GCS, just to identify the more severe patients. We're treating everyone the same, from our mild, younger flu symptoms to these obtunded folks in the skilled nursing facilities. But so the point scale looks like it might work really well. I don't know if it's necessary to go that far, but I think we could at least more parallel the pediatric protocol and add some of those clear indicators. I think things like temperature are still frustrating pre-hospital. We don't seem to be able to tell the temperature of a human body yet accurately, consistently. But I just wanted to ask too what your thoughts were, because it boils down to saline boluses for these patients pre-hospital, and the efficacy of that with these severe ones, I would think is very beneficial. But we're doing a lot of it on these mild folks and younger folks that just seems very unnecessary.
Yeah, and our next discussion is going to be about fluids, so I might answer that question for you in just a minute. But yes, I think that incorporating more of those criteria like we have for pediatric absolutely is important.
And I wasn't sure of the hospital's criteria for what they call a sepsis alert, because we have seen that off and on when we will be treating them under sepsis protocol, but it won't necessarily be a sepsis alert in the hospitals based on which one you go to, maybe.
Yeah, I think it is interestingly very hospital based. And so, the way they develop their triage scores, their sepsis alerts can be based on any medical history that puts them at high risk. And then it's usually 2 or more changes like we've listed in our protocol. So high temperature, tachycardia, plus something in the medical history that makes you high risk, or your age that makes you high risk. Sometimes it's 3 or more. And so that's where I think we start to see differences between pre-hospital and hospital. I don't know if that answers your question.
Yeah, I think so. I think just at least adding a GCS and an age are pretty objective criteria that we could get good at. That might help us better accurately identify the acute ones.
Are there any other questions and comments at this point? Don't see any. I assume, Todd, your hand is up from before and not a new one. Thank you.
Perfect. Thank you all so much for your questions. All right, so moving from our identification and that golden hour concept into our resuscitation, and here's where we're going to break down more about our ABCs and specifically our fluid management. So the first thing in our airway breathing model, right, is going to be our oxygen. I had this drilled into me by critical care and ER attending, so it's now just become one of my soapboxes. But one of the easiest and best things you can do early on in any patient that you think is in any shock state or potentially is going down that road of a shock state, sepsis or otherwise, is put them on oxygen regardless of their oxygen saturation. And what that has to do is optimizing your oxygen delivery, right? So if our fraction of inspired oxygen at room air is 21%, but we're able to supersaturate that hemoglobin and provide better oxygenation with a higher fraction of inspired oxygen, whether that's nasal cannula or a non-rebreather, then you're essentially just slowing down the effects that you see from anoxic tissue injury and hypoperfusion. So all of our patients that we identify as sepsis patients on that continuum, especially our severe sepsis septic shock, should be on oxygen regardless of their saturation. And again, that's just one other easy way that we can mitigate and intervene their progression to severe sepsis septic shock as we're taking care of them. Circulation. So this is what we talk about as our first line therapy for septic shock. We want to get those IV fluids on as quickly as possible. Our goal is to, again, restore perfusion, limit end organ dysfunction until they can receive sort of definitive diagnostic and treatment care. We'll talk about antibiotics a little bit later, but perfusion, fluids, very important at the get-go. So again, like we talked about at the beginning, septic shock causes vasodilation. So you have pooling of those fluids due to A, capillary leak, and B, just that vasodilation in the periphery, not able to get back into that core spot where you have it in your important organs. The pump, pumping those fluids through is working harder. That cardiac output goes up, right? Your heart rate goes up because you have the peripheral pooling of the fluids and the vasodilation. So the more you're able to give fluids, the more you're able to increase that return of the blood flow and then increase the perfusion to the periphery and to the organs. The only little caveat here, my jumbled explanation of that, is to be careful of patients who do have severe malnutrition. So thinking of our patients that we might identify in our housing insecure population, in some of our long-term care facility, dementia patients who have stopped eating. Those are the populations I would think of as potentially being at risk for severe malnutrition. And then we have obviously a large population of patients who have heart failure and are more likely to have third spacing and cardiac overload. So these are the patients that will probably get worse with very rapid aggressive fluid boluses. That does not mean that you should not give fluid boluses in septic shock. It's just something that we really need to be aware of and realize that moving to push dose epi earlier in those patients is going to be beneficial. So we'll talk a little bit more about push dose epi as well in a minute, but I really wanted to bring up that caveat because that is something that will start to give fluids and then notice patients are worsening with fluids, and it's often because they're in this population. This is just a study from 2014 that supports the fact that giving fluids is good for your patients. So that's all this is saying. Nothing else there. The type of fluid. So I think the type of fluid and the volume of fluid is something that we're always talking about, especially when it comes to sepsis. A lot of the literature comes out of critical care journals, but is applicable across the board to pre-hospital patients. And really what the discussion has revolved around is this idea of normal saline in our crystalloids versus lactated ringers, which is considered a balanced fluid. I think from a supply and production standpoint, normal saline is more readily available. That's what we are stocked with. And the goal across all of these studies is to say that yes, we want to look at the type of the fluid, but giving fluid is what matters. So if what you have is saline, give the saline. But if you have both, they've started to lean more towards the balanced fluids like lactated ringers as potentially being better for long-term outcomes in patients, simply because of the idea of the chloride in saline potentially worsening acidemia, which then can lead to cell dysfunction and destruction. In talking to a couple of my colleagues that I know in critical care and emergency medicine, they have started leaning towards LR if that's available across the board, because they're superstitious of this idea of hyperchloremia. But again, the studies are still sort of equivocal in terms of what they support. That being said, I have noticed quite a trend towards using LR in hospital-based settings for septic shock management. So I think it's an interesting conversation. I don't think that it has filtered into the pre-hospital space in the same way. And again, a lot of that has to do with what we stock our ambulances with. But it's an interesting point to bring up. One of the points against LR that many people will bring up is the fact that, yes, it's balanced, but it does contain potassium, it contains calcium, and both of those, as we know, could lead to issues. Calcium can cause problems if you're giving another agent. Sometimes it will not be compatible with calcium, and so it might lead to problems with what else you're giving your patient. People are always worried about, right, your potassium as your cell destruction is happening is being released into the vascular space, and now are you going to potentially lead to tachyarrhythmias in patients who are having hyperkalemia. So that's why I think this is a complicated discussion that hasn't really reached a consensus for the pre-hospital space, especially, but an important one to highlight and to discuss. Colloids, just a brief mention here, will often be used in ICUs down the line to help fix fluid overload from the initial fluid resuscitation, but should not be used largely in the initial resuscitation. This was a study from 2020, again, just asking what fluid type is the best. They looked at 7 different fluid types. They found that balanced crystalloids were better, that they reduced mortality more than saline. But again, this was really looking in the ICU setting. So this just summarizes exactly what I've already said. Generally, LR is becoming the preferred fluid, but give normal saline if that's what you have. And then the other side of that is the fluid volume. So one of the things in our protocol that I think, and I highlighted, is interesting is that for adults, we say, irregardless of breath sounds, give the fluid. For kids, we do say, be careful if you hear rails. I think you're more likely to hear rails in adults, just with the number of medical problems that you can see, with the larger proportion of heart failure patients that you can see, and starting to see that fluid overload is a sign that you should move towards a pressor or a push dose epi. So I think adding to our protocol, checking breath sounds will be really an important addition to that protocol. I think it's a big discussion, and I'd be curious what people's thoughts are. But I actually do think that the fluids shouldn't necessarily be irregardless of breath sounds for that second or third bolus. Potentially that first bolus, go ahead and give it. But if you're hearing rails, if you're hearing those crackles on the second or third bolus, potentially pausing, not giving that fluid and giving the push dose epi instead would be an important variation to the protocol. So just a quick pause if anyone has any thoughts on that. If not, we will move right along. This idea of fluid volume.
There's one comment in the chat that
Sure.
says that consistent would be great, kids and adults. Thank you.
Yeah, perfect. And I apologize, there's a construction vehicle outside if you hear background noise, but moving forward from fluid volume, I think for us in general, we're giving aliquots of 500 cc's. For kids, it's more based on that 20 cc per kilo model, kind of getting up to that 60 to 80 cc per kilo range. That's adopted from this idea of the golden hour in the in-hospital setting. I think you have more of a variation of how much fluid you should give when you really look at the literature and when you talk to people in practice. A lot of times it's less if they're already at that severe sepsis point, because you do start to hear rales earlier on because of those leaky capillaries. But you can give upwards of 100 to 120 cc's per kilo if that's what it takes. And then ultimately down the line, the ICU will work on fixing fluid overload issues. But for our practice, I think our current model using those 500 cc aliquots, but for the second, third, fourth boluses, being aware of rales is really the best way to treat volume. And then we move into this idea again of push dose epinephrine. I think after reviewing the literature, especially in our adult patients, but I think in our pediatric patients as well, moving to making that first dose of push dose epi a standing order, trying to, again, be aggressive in your initial resuscitation, limit the delays to giving the patient the care they need is critical. And the protocol as of now says that any push dose epi needs to be a base hospital order. So my recommendation would be that first dose is a standing order, subsequent doses at that point, obviously dealing with a very sick patient, potentially could be a base hospital order, something that you're talking to the base hospital about with this patient, which is also beneficially then encouraging your communication with your destination ER to say, obviously, this is a very sick patient, and here's where we're at. So that would be, after reviewing the literature, my recommendation. In general, many of the studies show that 28 to 70%, very broad range, of patients require continuous infusion of pressors after receiving a push dose pressor. So again, that's where you're also optimizing your communication. You're allowing that receiving facility to be ready with pressor support if you're continuing to have to give multiple push dose EPIs. From our standpoint, we give push dose EPI, so we're fine. Systems that use drips would use norepinephrine to start with because of the fact that it helps with that vasoconstriction, combats the vasodilation, but that is not something that we need to worry about right now with our protocols. This is just, again, from the literature I'm taking all of these recommendations from. Some systems will prefer to use phenylephrine instead of epinephrine for previously healthy patients because of the idea that epi is going to cause a lot of tachycardia and doesn't necessarily help with that peripheral systemic vascular resistance issue that you're seeing with the vasodilation. So phenylephrine being an alpha agonist. That being said, I think using epi is appropriate based on the literature. So before I move to our last point of the day about antibiotics, any other comments or thoughts about fluids and pressors?
Well, I was just thinking about the comment you just made on phenylephrine and how that's not in the scope of practice in California, or probably most places for paramedics. And also thinking about our epinephrine shortages, which are not infrequent, and wondering if you had any thoughts about whether phenylephrine would be a good sort of a local optional scope of practice consideration at some point in the future.
I do. I think there is a lot of data to support it as a push dose pressor in septic shock specifically. And that the data is favorable, shows that it's safe, and it is frequently used. And so I think, especially with any sort of shortages, always important to look at our alternative agents. And because this one is favored for sepsis specifically, could potentially be a really important one to incorporate into a LOSOP practice.
Thank you.
Yeah, thank you. All right, so the last point, and I know I have just over 5 minutes, so I'll breeze through this, but antibiotics, do antibiotics matter as we're talking about sort of the last point in that golden hour bundle? Yes, they matter. So Here you're looking at patient survival based on time to antibiotics, and you can see that it drastically decreases the longer it takes to get those antibiotics on board. Again, hour 0 is the hour that you diagnose the patient with sepsis. So this patient's been living with sepsis, potentially has been sick for hours to days. We don't know when we're meeting them, but the longer you delay antibiotics, once you identify sepsis, the more likely they are to have decreased survival. So one of the summaries from 2006 essentially calculated that out and said, for patients with severe sepsis, septic shock, every 60-minute delay leads to a 7.6% increase in mortality. So this is an area that, I guess in the pre-hospital sphere, what I'm trying to say is long transports, patients that are not necessarily urban with easy access to emergency departments could benefit from having antibiotics available to give to patients they identify with sepsis. The timing really does matter. I already mentioned that 7% sepsis without shock, the mortality increases 1 to 1.5% per hour for the first 6 hours, that treatment is not adequate. And this supposes that these patients are bacteremic and not viremic. There was actually an RCT conducted in 2017 that was over in the Netherlands that looked at the idea of antibiotics or not antibiotics. Interestingly, they did not think that it improved survival to use in the pre-hospital setting, but that the education and the communication from pre-hospital to hospital setting is what did improve outcomes in patients. But here you can see, 26 minutes, almost a 30-minute time from antibiotics given to ED arrival. When I looked at the actual sort of geography, these are longer transport times. So I thought that that was an interesting RCT, but this other article that was more recently published in 2022, looking at pre-hospital administration of antibiotics for sepsis patients, it was a systematic review and meta-analysis, actually supported pre-hospital antibiotics, saying that they lowered the 28-day mortality. So I'm sure that the truth lies somewhere in there. But again, this is the issue. We always have these competing studies trying to find what really is the best practice. I think ultimately what we know is the sooner you give antibiotics, the better. But the system that you're in and some of the barriers that you have to overcome do matter. A lot of the rationales for exclusion of pre-hospital antibiotics include allergic reactions, the cost, the training, the storage, the fact that most of the time hospital-based providers are going to want blood culture samples before. So now suddenly we are becoming a mobile lab. We're collecting blood samples. And so for the inclusion of this, many of these systems are hospital-based, where the hospital can act as the lab for that EMS system. Greenville, South Carolina has initiated antibiotic use in the pre-hospital setting, but in order to do that, they agreed as a hospital-based system to collect both a blood sample that they can deliver as well as blood cultures prior to administering this. So that has a mountain of complications and barriers that go with it, and definitely is not something that would be easy. And they have 2 antibiotics available. They have ceftriaxone and they have Zosyn, depending on the suspected source. So they give the ceftriaxone if they suspect that the source of septic shock is pneumonia, and Zosyn for everything else, which I thought was interesting as well. But again, this comes down to storage, supply. It's just another convoluted way to implement a new medication into a system. And based on the fact that Greenville has that, I was curious if other systems had. I could not find a lot of systems. I did want to highlight 2 others that have a couple of changes compared to our current San Diego protocol. Neither of these, Wake or Maryland, have antibiotics in their protocol, but Wake has end-tidal CO2. You'll see after the initial vital signs that they use as criteria, really more to support those vital signs, but very similar to ours, except for the fact that they incorporate GCS. So here you see the 4 that we would have included. For adults, actually, they include blood pressure, but they include GCS. And then they also have a sepsis alert protocol. So they will activate this alert if the patient meets criteria. And their EpiPush is a standing order. And then Maryland, summary basically to say, they include hypotension as part of their 2 of the following for adults. And then this is a sepsis alert as well. So I think it's just interesting to see the variations, see how we can adopt those for our own protocols and to make ours a little bit better. I'm going to go back to this, but again, since we were talking about it already, I think for the adult protocol, incorporating in mental status, potentially age and blood pressure are important additives that can just help us better identify and classify severity. I think that potentially here, when you see after the initial fluid bolus, give a second regardless of lung sounds, we actually should pay attention to rails here. And then I think that that push dose epi for the first dose should be a standing order, potentially then base hospital order for additional doses.
There's a comment
Yes.
regarding the BLS side of that
Yeah.
Christine put in the chat a little while back.
Sure.
Back to the emphasis placed on providing oxygen, the current sepsis protocol states O2 PRN and not as a definitive treatment. And I know you said you got that deeply into you, so you might want to emphasize that again.
Yeah, thank you for catching that. I, even in my soapbox, hadn't noticed that. So I agree. I think every patient should be placed onto oxygen, irregardless, for our sepsis protocols. So not PRN, just an automatic place onto oxygen. Thank you.
Yeah, I think we need to remember too, oxygen is a drug.
Yeah, yes, that is very true. So all of that brings us, sorry, a minute over, but to our summary. So again, already reiterated a lot of these things, but infection with clearly defined changes to vital signs in clinical exam are indicators of sepsis. Our point of care lactate discussion in the pre-hospital setting may be used as an adjunct, but very complicated to implement and costly to systems, and should not replace current diagnostic protocols as it is. Early warning scoring tools like QSOFA may be used in addition to our vital sign parameters to provide a sepsis alert to destination facilities and provide streamline of care so that hospitals are receiving those sepsis alerts even before the patient arrives, even before they're doing their own triage of the patient. Our resuscitation should include oxygen, early fluid administration, and pressor support. And I think there's always a discussion about pre-hospital antibiotic implementation, but it is very complex. And so something to consider potentially for prolonged transport times, but maybe is not going to be worth the cost for short transport time agencies. Thank you.
Thank you very much. That was outstanding. We really appreciate all the work you did and the collaboration with the experts and literature you reviewed. That was a big project, and I know you created it just for our group. So thank you very, very much. Are there any last questions or comments before we wrap up? Some kudos coming in the chat.
Well, thank you all so much for your questions and your engagement. It made it much more interesting than just my voice.
Right. Thank you again.